which is a little bit. There we go. Okay. So I'm going to go pretty much through it, and if you have questions in the middle, I'll take a peek at some point, and then we'll certainly have time for questions at the end. So I'm just going to get right going here. Um, let's see what first thing we got to do. Yeah. So introductions, you've heard a little bit about it already. This is about questioning and about having questions. And if you have questions now, we talked a little bit about that. If not, there will be time later. So this is I'm welcoming you in an introduction. And the first thing I wanted to start with is some basics. Is where do I come from? I'm the speaker. The ideas are coming out of my mouth. So the first question is, do you know the doc, and does the doc know the patient? I was on a hospital discharge meeting yesterday with a patient that I have not taken on yet. One of the schools I worked with at the Center School for Crisis Assessment and Stabilization out in Holyoke, and I'm now doing stuff on Zoom with them, of course. And the child was being discharged from the hospital, and the clinician had been working with this child for 2 years. The doctor didn't know that the child had been in and out of the hospital 15 hospital or residential program or crisis units 15 times in the last 2 years. So the doc had some great ideas and had stabilized the crisis, but did not know the history. So the doc should know the patient, and you should know the doc. So this is my history. I actually was an aide in the special needs classroom. That's why I didn't need to give a big introduction. I did that when I was right out of college, and it got me interested in special education. And then I took pre-med courses. While I took pre-med courses, I taught high school science and at a school on the lower west side of Manhattan. I was an aide on the lower east side, and then on the lower west side in Soho, in the artistic neighborhood, I taught science to the children of artists. I went to medical school. I did residency in Brooklyn, New York, Kings County Hospital, and then UCLA for child psychiatry. And I'm board certified in adult, child, and adolescent, and in forensic psychiatry, which will be relevant a little bit. I've been with the May School for Brain Injury for 25 years and the Center School for about 20. And I've worked at other schools, and that's my background. And I have private practice. And importantly, I don't have any conflicts of interest. I don't have investments in drug companies. Drug companies have never given me money to talk about their drugs. And I don't have a book or something, device of my own that I'm promoting. I do have a treatment philosophy, and rather than telling it to you, I'm sort of going to show it to you as we go through this. And then the warning that this is information. It's up to date as of this minute. I hope, at least I've strived for that. But you shouldn't use it to make a medical decision. So you want to know where your child's doctor is coming from, and you also want to let the doctor know where you're coming from. And I said, even if they don't ask, and then I said, well, especially if they don't ask, because they're not going to be asking themselves that question. You got to let them know, doctor, do you know that so and so had actually been in 15 programs in the past 2 years? He had a lot of great ideas, but he didn't know that. So the second question is, and this is in some ways, this is the foundation. If this talk is a house, this is a well-laid concrete foundation of information that couldn't be more important. People have to give consent. If I was to treat someone without consent, that would be considered a battery. That would be an attack on their person. You have to consent for me to do something to you, whether it's a physical examination or to give a medication. I don't sew people up like my son, who's an emergency room doc. But people need to consent, and it needs to be informed. And the reason, like, what is this stuff after the word consent? That's reference to not a Supreme Court, a district circuit court case. It did not go all the federal second district, did not all go all the way to the Supreme Court, but it happened in 1972. And Mr. Canterbury wasn't told about all the possible risks of his spinal surgery, which went poorly. And afterwards, there was a lawsuit, and the settlement was the doctor should have informed the patient, not what the doctor thought the patient should know, but what a reasonable person would be expected to want to know. So it went from shifting to the doctor to the patient, that the patient's right. The patient had a right to know. And these are the things that are considered the essential elements of informed consent. And when I do my forensic work, when I review a chart, I want to know, and something has gone wrong, did the doctor inform the patient or the patient's parents or guardian with consent? So people have a right to know, what the heck are we treating? What's the diagnosis? What's the name? What does it mean when somebody has a diagnosis of such and such? Diagnoses are not just labels, they imply a certain trajectory. So a diagnosis is very important. Sometimes, we'll mention at least one other time in this talk, you don't really know what the diagnosis is. You know what the problem is. The problem is someone has trouble sleeping. The problem is somebody gets very dysregulated and becomes aggressive. That's not a diagnosis, but you can go at it with just the knowledge of there's a problem. It's a little bit different, and you want to try to find out what the underlying diagnosis is. So diagnosis, and then the proposed treatment. Proposed treatment is, you start on this medication, we're going to start at the low dose, we're going to go up. What's supposed to happen? The expected benefit. The symptoms are going to diminish, hopefully. That's what we hope for. In frequency, intensity, maybe they're going to go away. If you're treating, for example, ADHD, the person will now be able to focus. They'll be able to stay on task. The persistence, they're more likely to stay with the work and not get distracted or not become impulsive. That's the benefit. What are the risks? Well, the risk with stimulants, for example, would be someone loses their appetite. It disrupts their sleep. And I've seen in a few cases, these are controlled substances. They get diverted and they get abused. If they're used correctly, they're not addictive. In fact, children who have ADHD, who have been diagnosed appropriately with it, who take stimulant medication, have a lower risk of substance abuse than those who have been diagnosed with ADHD and were never given stimulants for treatment, because they learn a capacity for self-regulation and a respect for these medications. But those are potential risks. Every substance that we ingest has a potential risk. Understanding what that is and weighing the potential benefit and the potential risk is part of the informed consent. A very legitimate question is, what is the risk of doing nothing, letting nature take its course? Of course, there's no such thing as doing nothing. It's an alternative treatment. If people are going to either eat healthy diet or not a healthy diet, they're going to engage in a healthy amount of physical activity or not. So even if they don't take a pill, they're going to regulate their sleep, they're going to regulate their alcohol intake, their food, their exercise, many things that have profound impact on physical health and mental health. But we call that the risk of doing nothing, because the doctor feels like they're doing nothing because they're not picking up their prescription pad. Here's mine right here. They're not picking up their pad and they're not writing a prescription. So if you're not writing a prescription, that's, quote, doing nothing. But a lot of doing nothing is sometimes allowing nature to take its course. Now, with certain illnesses, like, for example, manic depressive disorder or psychotic disorders, that can be a very dangerous thing. And so that was the risk of doing nothing. And then the risks and benefits of alternate treatments. Now, when this was conceptualized, alternate meant, what if we give this type of therapy versus that type of therapy? It did not include alternative treatments, such as alternative and complementary medicine. I'll get into those in a little while later, because doctors, by and large, don't know a lot about that. Back in my days, when I was doing the teaching and before I went to medical school and stuff like that. I actually lived in the back of a health food store for a few months. I know a little bit about complementary and alternative treatment. As you'll see later, I also know people use it a lot, but this is about alternates within the spectrum of either FDA approved or community standard medications or treatments that are used regularly. Now, underneath there's this another case from 1985 about Osheroff versus Chestnut Lodge. Why is that there? Dr. Osheroff was a very successful nephrologist, a kidney doctor, and he had a number of clinics, and he had set up, and people were getting dialyzed. He became profoundly depressed, and he went to the Chestnut Lodge, which was an institution that treats mental illness, and it's sort of old-fashioned. They used only psychotherapy. He didn't get really well. He was there for a long time, and his business failed. He wasn't able to follow his business. His business failed, and eventually he went somewhere else, and they said, we have this thing called an antidepressant. I forget what he was on, because Prozac came out just around this time, so it might have been Prozac. And he took an antidepressant, and whammo, he got a whole lot better fast. And he said, he looked around him, and his medical empire no longer existed. It was destroyed. So he sued Chestnut Lodge successfully, because they failed to inform him of the risks and benefits of alternate treatments, that, you could have intensive psychotherapy or you could take this antidepressant. In that case, the extensive period of time he spent in Chestnut Lodge without benefiting, they should have considered the alternative. So there's more than informed consent. Those were the basics. That was the legal standard. You're also going to want to know what the common side effects are and rare and concerning side effects. Something that might look like a pretty benign rash in the context of certain drugs could be very concerning, for example. You'll also want to know, well, if these side effects exist, how are you going to monitor for them? Weight gain, for example, is a common side effect with a large number of medications that are prescribed to children. How you monitor for that is you check weight and body mass index on a regular basis. And what do you do if the side effects happen? Well, that may mean, do you switch to another medication that's less likely to cause weight gain? Do you strictly enforce diet? So these are questions, again, that you would want to ask when the doctor is getting informed consent, which should be obtained before starting any medication, should be documented in the chart. And as one of my mentors, Dr. Thomas Gutile, said, informed consent is not a one-time event. It's an ongoing process. So the informed consent should be refreshed. Like I mentioned, there are some drugs that can cause a dangerous rash. When I'm talking to patients and I'm renewing this prescription, say every 6 months or a year, it says, you remember what I said about that rash? It says, yes. And it says, so I'm just renewing the informed consent. It's not just a one-time, one and done. So the next question is, we went to school forever. We learned a whole new language that separates medicine from the rest of the world. It used to be a lot more Latin, but it's like, what are we talking about? Can you explain what that term means? And here's just a couple of terms that come up sometimes. On-label and off-label. On-label means the Food and Drug Administration says, you have met our standards, which include things like it has to be better than placebo, not better than the current medications that are out there on the market, just better than placebo. If it's better than placebo, then you can claim, and we think it's better, we will approve it. The Food and Drug Administration will approve this medication for stabilizing bipolar depression, for treating unipolar depression, for ADHD. So it's approved, okay? Off-label would mean it has no approval. It might mean that there's a lot of good research articles showing that it works. For example, the drug 10x guanfacine. I was at a center at UCLA where they were doing research and people were using it, but it was not yet FDA approved. It is now Food and Drug Administration approved. So, but it was off label. And I would say, hey, we're using this drug that's off label. Some people think that a derivative from pine sap called pycnogenol was useful to treat ADHD. There is no literature to support that. It's a theory. You can buy extracts of pycnogenol online. They're very expensive, but they've never been shown to work. So that's also off-label, but it has no evidence. So off-label doesn't mean it's bad, doesn't mean it doesn't work, it just means the FDA doesn't approve. But it's different than FDA, but you should know. And then so that's that. So then we have something, a side effect, or what we sometimes call adverse events. Medications are unruly. When somebody puts them in their mouth, it will go anywhere it wants to in the body, not just to the receptor sites that we want them to go to do the effects that they want. So we get benefits and we get side effects. Medications can help calm people down, but they can also make them sleepy. They can cause auditory hallucinations to go away, but they can also cause weight gain, or they can cause abnormal involuntary movements because they register at receptor sites in different parts in the brain or even in the body. There's receptor sites for serotonin in the brain and in the stomach. So when people take a medication that increases the concentration of serotonin, like Prozac, it can do things like lift people out of depression, but it can also cause diarrhea. So that's because medicine's going to do what a medicine's going to do. It's going to go where it wants to. Then we talk about cure. Cure means adios, goodbye, nice knowing you. The symptoms are gone, they never come back. That would be a cure. In reality, what we see a treatment response, that people get better. And we consider it, if people get 50% better, that's awesome. But what you'll see is a decrease in the disabling effects of whatever the symptoms were to a certain extent. There are medications that are used to treat post-traumatic stress disorder. They do not, like Etch-a-Sketch, remove PTSD from the brain, but they cause a decrease in the intensity and sometimes makes the symptoms less disabling. But these are terms, and there are others, but these are just three that I put in there. If the doctor says something, can you explain what that means? Then the fourth basic concept is that preferred drugs and use of drugs change over time. So here we have two rather embarrassing advertisements from the very fairly recent past. I wish that I was in a lecture hall or a discussion group with you right now, because I'm missing your smiles and your laughters, but these are highly embarrassing. We have a doctor recommending smoking cigarettes in the 1930s. At one point, there was a theory that it was good for asthma. Again, this is no evidence, current evidence for that. And then, yes, in the 1940s, doctors did prescribe amphetamines to women, mostly, who wanted to stay fit and slim. And, it's important, knowing history can be important, and history can guide us because those are the fashions and mistakes of the past. It's interesting to ask, what are the mistakes and fashions that we're making now and that, a few decades future are going to be equally embarrassing? We don't know what they are, but I look forward to seeing them. So that going forward is the next question is, so when is it reasonable to think about psychopharm and to giving to a child? When is it reasonable to think about giving a child a medication? This is a huge question, really, really huge question. And there's a variety about that. The answers range from yesterday to a much more cautious approach taken by a number of organizations that look at these things somewhat scrupulously. I pay a lot of attention to the National Institute for Clinical Excellence, or NICE, which comes out of the United Kingdom. And what's interesting about that is the influence from drug companies is much, much less, or maybe even zero, but I don't know, than it is in the United States. And this is because there is a one system, one payer health service, that the drug companies don't get to influence prescribing recommendations as much as they do in this country. And the recommendations from the United Kingdom is basically for almost all conditions, medication is not the first line. Exceptions exist like ADHD, but even medications that treat, for example, depression, they're not that effective in children. And it is recommended that therapy be undertaken first, but a specific type of therapy, for example, like cognitive behavioral therapy. So medications are the first line of treatment in psychiatric conditions sometimes, but not often. And so what is reasonable to do before you undertake a medication trial? Well, there are certain treatments that are evidence-based. For example, there are a number of treatments for post-traumatic stress disorder that are, most of them are cognitive or cognitive behaviorally based, that have been shown to effectively reduce symptoms. And so that is considered a first-line recommendation by NICE and by another organization called the Cochrane Review. And the Cochrane Review is an organization that takes all the studies that have been done on a question like drugs that treat depression or medications that treat PTSD, or therapies versus medication for these things, looks at every single published study, rejects the ones that are of poor design, and says the ones that are of good design, they go to the authors of those studies and say, would you please give us your original data? We'd like to recalculate the conclusions that you reached using your data. And they will aggregate those conclusions to the extent they can and make meta recommendations. So there's no slide about Cochrane in here, but it's COCHRANE, but very, very powerful lens through which to weigh the value of certain evidence, of certain medical evidence. So when do you use it? So the first line is look at these therapies, find someone who can do these specific therapies well, and give them a trial. On the other hand, I've worked in the emergency room. I was a gatekeeper on psychiatric emergency rooms for children when I worked in the managed care world. Sometimes, even though you don't know a diagnosis, even though you have either treatments in place or on the pipeline, the risk of injury to self or to others. I do know of a case of a kid who would run out of the classroom. He ran out of the classroom. He ran into the street. He was hit by a truck. He's alive, but he was hit by the truck. He had some minor brain injury, but he was impulsive. And medication clearly, in some instances, takes precedent over knowing everything about what's going on, because the risk. Again, the risk versus benefit is informed consent, which is why informed consent is the base level, the foundation of this thinking. The potential benefit outweigh the potential risk or side effects. This child is at risk of harm to themselves or others. So that moves up on the timeline a whole lot sooner when you would give medications. And then, so what do you give it for? The fact of the matter is, psychiatric conditions, symptoms are not equal. This is one of the least scientific slides in the entire presentation, but it's based on a quarter century of clinical experience and some research. The response, for example, of ADHD to stimulant medications is one of the most robust responses of any condition in all of medicine, not in psychiatry, any condition in all of medicine to a drug. So they get like a 75 to 90% response rate, depending on which drug, and sometimes you need to go to the second drug to get 90%, in terms of reducing the symptoms of ADHD by using a stimulant medication. There is no cardiac drug that is 90% or even 75% effective. So it's very, very impressive results. Childhood depression, it's better than placebo. Bipolar disorder, juvenile onset bipolar disorder is very hard to stabilize. It may take multiple medications, multiple trials, but as I say, mostly psychosis. If someone is hallucinating for whatever reason, responses to antipsychotics are pretty good. Tourette's syndrome, again, not eliminating it, but reducing the severity, the frequency, the intensity of these symptoms makes a difference. Down at the bottom, conditions that are comorbid, people who have ADHD, who have autism rather, people who have autism oftentimes have problems with sleep, with anxiety, um, and both of those things can be well treated. And also ADHD symptoms. The problem with treating ADHD in someone who has autism is oftentimes the side effects eliminate any benefit. So that's why it can, sometimes it's mostly, but these other things on the right side, things that involve attitude, things that involve a degree of intention, that are more strictly behavioral, are less likely to respond to medication unless they are, oops, let me go back, unless they are a manifestation. So for example, a child who is depressed, a child who's been traumatized, may show a bad, quote unquote, bad attitude. So children who are having PTSD and dissociation have been accused of lying. They're not lying, they're dissociating. So it's wrong to call them that. So even these behaviors need to be more carefully parsed before you can say that they won't respond. So what can you expect from a medication? You expect relief. Um, what do you expect from a prescriber? Let's take a deep dive into it. So I was asked a while ago to think of what does it look like in general when somebody is doing a good job. And these are my thoughts based on the ideal, or what I hope I'm doing, or my colleagues are doing, and sort of how we are trained. So the first thing is, what I said before, the doctor knows the patient. And one of the most sensitive diagnostic instrument we have to understand what is wrong with somebody in all of medicine is not some fancy new multi-million-dollar machine. The most sensitive instrument still is the history, and getting a good history is an art, and sometimes there's not enough time, and sometimes I've been involved in situations where parents have just given up on trying to give the doc the history because the doc is moving too quickly and doesn't want to know. Other times, parents are very invested in history, and they have what I call the notebook. I said, did you bring the notebook? The notebook has every IEP, every psychological, every neuropsych testing, every discharge summary that has happened. So I said, can we make a copy of the notebook? I will read the notebook, which can take a lot of time. But history is critical, and history should precede diagnosis, because without history, you could make errors. So you gather information. Again, multiple sources is important. And then before you make the treatment, you have a diagnosis. And part of the diagnosis is knowing what the environment is, because children, even more than adults, are very sensitive and reactive to the environment, what's going on around them. Are people moving in and out of the house? Is a grandparent having, a serious medical issue, something like that. Part of the diagnosis is knowing what substances enter a patient's body. For older kids and teens, that could be, drug use, but a lot of times parents will also use complementary and alternative medications. In my experience, they don't feel like they have permission to talk about that. Sometimes the results can be helpful. Sometimes they can be benign, neither helping or doing anything. But I did part of my training at UCLA. I was involved in a number of cases which I was called to the emergency room as the child psychiatrist on call. There are a number of herbal remedies, most of them are off the market now because we're talking in the 1990s, that could induce psychosis. They were thought to help with general alertness and things, but they contain, for example, ephedra that could make people highly agitated, and other things that can cause psychosis. And I saw, and the parents had not informed the doctor who was treating the kid that they were using these herbal remedies. So it's important to know what's going on. And then you obtain informed consent. And from the child, you want the child's assent. Minors cannot legally give consent. That is part of the role of the guardian, the parents. But again, it's about knowledge, and informed consent means you know something. It's a two-word answer. There's information and there's consent. So that I should say there should be informed consent and informed assent. I should rewrite that slide, because informed assent means talking to the child at whatever developmental and intellectual level they are at and giving them a fair appreciation of what's going on. So it should be informed assent. Just caught that. And then there should be a plan. I actually heard this once. A doctor who was discharging someone from a hospital said, I don't really have a lot of time, so I'm just going to start them simultaneously on 4 different medications, and the outpatient doctor can sort it out. That is not good medicine. But I was on the phone, as in my role at the insurance company, trying to work around quality that was going on. So a plan could involve target symptoms, that there's this aggression that happens with a certain frequency. And we think it is to do with just that they are easily triggered. What are the best practices? There are algorithms, decision trees. If this is the symptom, try these medications first. They have the best evidence. If those don't work, try those. That would be decision tree or algorithm. Input and questions are critical from patients and parents in formulating the plan, but there should be a plan. What is practice ongoing practice? It's just not one and done or set it and forget it. Is the person responding to the medication? Even though the medication may work for a lot of people, it may not be working for this person. So it's really important to ask those questions. And if there's side effects, you want to address them as well. The charting should reflect, are we meeting the goals or not meeting the goals? Sort of like a business plan, a 6-month review. Are we getting there or not getting there? As opposed to ongoing prescribing the same medications for year after year and not getting there. And sometimes what people need to stabilize and what they need for ongoing practice and care are different. So minimize that. 30% of all drugs never get taken. And you know what, folks, I confess, I am part of that 30%. I have not taken every pill that's ever been prescribed to me, just saying. So medication compliance is an important thing to check about. It doesn't always happen. And ongoing consent, as I said before, we review. This is what a psychiatrist needs to know. What's going on in this child's world? How well are they functioning? It's not the only index, but it's a good window into what's going on. And there's many different reasons why people aren't functioning well. And these are some of them. Are they paying attention? Are they persisting? Or, and people could just have given up because they're feeling depressed, they're overwhelmed, they're worried about problems in the family. They be spending too much time looking at screens. All these things are important. You want to know how well they're relating to other people, even in these pandemic times. What's going on? You want to know what they do when they're not in school. How are they using their life? If all they're doing is sitting alone in the room on the computer, that might be contributing to their depression if they're having it. Sleep is a very sensitive indice of what's going on. The whole field of sleep medicine as a separate specialty is less than 20 years old, and understanding how it's a phenomenon that's highly sensitive to just about any sort of perturbation. Medications can screw up sleep. A few can facilitate sleep, but no medication can give you good sleep. Nobody's ever woken up out of general anesthesia, stretched their arms and said, I just feel great. Sleep is very sensitive. It's very delicate. It's hard to improve on. Many things can screw it up. So you want to know about disruptive behaviors, tantrums, aggressions, what's triggering it, what's going on. These are important questions to ask and try to zoom in and get details. You also want to know if the child is the same all the time, or there's this variability, which raises a bunch of different things. And I thank my good friend and colleague who's over at the Walker School, Chris Belanci, who no, he's actually at where's he? He's not at Walker. He is at what school is he at right now? I don't remember actually, but I worked with him at Tufts for a number of years, and just a really great psychiatrist. So what else they need to know about the inner world? If people are moody, it's important to ask about suicidality, because some people know that, so not everybody does. But it's important to stress that. And ask what is a child worried about. Sometimes it's reasonable, sometimes it's not. Appetite can be a function of a lot of things. Medication can affect it. Kids who are despondent aren't necessarily eating, and about their general energy level. And if they seem to be doing things that are bizarre, parents may not want to talk about that. It's important to talk about it. What do you get from meds? As I said, you should get a degree of relief for yourself and for the child. The question is, how much improvement? That varies. A lot of times, what's promised in the literature is not exactly what's there. So you want to find out what's going on. What if some things get better and others don't? These are the complex questions to sort out. This is what happens in a meeting with the child psychiatrist. These are the sort of questions that the time should be devoted to, not just a single, is he good on the meds or not good? So how do you choose a med? There's a lot of ways to choose a med. This is not one of them. Sometimes you choose them based on side effects. This lovely, very colorful grid is actually from Canada, from a Canada medication prescribing project. There's nothing like this that I've seen from the United States government. And just to appreciate it in general, there's a bunch of different side effects and there are a bunch of different medications. And sometimes you choose a medication from a class. These are all antidepressants based on the side effect profile, if you know that you're choosing antidepressants. So one way is choosing by what meds don't do. Okay. But the thing to know is, this is one of my mentors, Dr. Dennis Cantwell. He says, it's a challenge to know what's going on with the kids. Sometimes you got some symptoms. It's very easy to diagnose people in their late 20s and their 30s. You've had lots of history, and whatever disorder it is usually shown its face. It's hard to know what a 10 or 12-year-old is really going through. You can guess. And Denny said, the diagnostic manual with the disorders is great, but kids forget to read the manual. They don't fall into those narrow categories. So you've got to work with that. So here are some questions that you can bring into your meeting with a child prescriber or psychiatrist. Some of these will be very familiar. They go back to informed consent. What's the medication? What is noted about its helpfulness? So you want to know what the doctor knows about the literature. How is it going to help? How long before it helps? The truth of the matter is, some medications, for example, if they work too rapidly, it's a sign that something is not right. Medications that make depression go away overnight, I think you have to question if it's really depression. And some medications can act in some circumstances, for example, to lift people out of depression. If it happens too rapidly, you worry about mania. So time frame is something. And again, some of the questions consistent with that informed consent. Not very few medications that we prescribe to children have addictive potential. Some of them can have what's called a tolerance, and they need to come off it slowly. For example, if someone is taking an anti-epileptic medication for mood stabilization, you need to stop it slowly so you don't cause them to have a seizure. So it's not addictive, but you need to stop slowly. And you want to know the range. You want to know, are we starting at the low end or the high end? What are the laboratory tests? How do you monitor this stuff, and how often? Important questions that should be answered. Does it interact with other medications in prescription and over the counter that the child takes, or you might give the child? I mean, they can't go over everything. Interactions with food are rare. There's this thing called the grapefruit effect. It doesn't play a significant role in most psychiatric medications, but interactions are important to know about. Any activities to avoid. This is rare, but these are good questions. We talked about not stopping meds abruptly before, and certainly for children over a certain age, and that age is unfortunately usually younger than we initially imagine, you should be asking about drugs and alcohol, and would they interact with these medications? How do you know if meds are really helping? Well, Like I said at the very beginning, I became interested in medical error. And medical error often occurs because of bias. And there are many different types of biases that affect decision making in medicine and in business and elsewhere. And these are a few. One is anchoring. That is the first thing that you hear, you use it as the basis of your decision making, even if you get more data later. Oh, I saw that this medication was awesome for the child down the street. So it's like you wait for it to be awesome for your child. It's not. The availability bias is a different bias. I was involved in a situation in the residential program where I worked at, which a lower functioning child was spitting at the staff. And I was at a team meeting where someone complained, well, he's still spitting. Well, we had started using face shields and instituting a behavioral program. He was, when he came to the program, he was spitting, every hour, every time someone made a demand on him. He was now spitting, 2 or 3 times a week. Yes, he was still spitting. The availability bias said it was still a problem. But if you looked at the curve, the symptom was going down very dramatically, very successfully. And here's one more bias, the confirmation bias. So the question is, I think something is true, and I selectively only review evidence that confirms my bias. I don't look or weigh all the evidence with the totality of the same. I find things that support my point of view. There's a lot of that going out there on the internet right now, going on. So I'm not saying there's going to be a test on these later, but these are useful to think about as how doctors think, and these are part of how doctors think, and how they may lead a doctor to make a conclusion that turns out to be poor because you're getting poor results. It's not poor because it was wrong. It's just like we need to do a course correction. So the Society to Improve Diagnosis in Medicine has articles and workshops and conferences that talk about bias in diagnostic error. And there's their website and 3 books that talk about how people think and make decisions and use information. And biases have an evolutionary benefit. If you see a woolly mammoth charging at you with their tusks aimed at your body, the bias is you're in danger. And so you get to respond quickly without having to think it through. But biases can also lead to poor decisions. So what do you do to counter bias? You quantify, you gather numbers. The wonderful Atal Gawande said, doctors should be a scientist. We should count something. We should measure. If you want to change something, measurement of what you want to change can be very helpful. And what measure is over here on the right. You measure behavior, the frequency, the intensity, the number of times it happens, and the duration of episodes, or find. And it's important to measure behavior because, again, oftentimes we mistake change and correlate it inaccurately, like on the left here. We think that the medication is the cause of the change when the change may be happening for other reasons, in which case the medication may be of very little use. So when do you stop medications? Are kids married to medications? Are trials off warranted? These are great questions. I could lecture for half a day on the nuances of how you go about this, but that's why child psychiatrists go to school for 9-10 years, start from this time they start medical school, is to sit down and have these questions and discussions with the parents. So it's an important question. I don't have the answers in this particular talk, but it's a question that needs to be asked. Should these meds go on forever? Okay. And then the question is, well, what about complementary and alternative medications? We spend $30 billion a year on it. So I think you have to include me in that. I am a long-term student of Tai Chi, as an exercise practice. That's considered complementary medicine. I do that. I drink herb tea sometimes. So not all of it is some latest, greatest thing that is advertised on the internet, but people utilize these things and they do have health benefits, some of them, not all of them, but they spend a lot of money. And 1/3 of all adults have tried something. And I've just mentioned 2 things I've tried. In cases of autism, various studies have shown parents who are desperate. Up to almost 90% of parents have used something, and they may not be telling the doc, which is why it's there. So parents are often ashamed, but I can't stress this enough, but it's important. But what I think about these things, this is very important. Dr. Offit, a local, wonderful, brilliant pediatrician, I don't make the distinction between conventional and alternative medicine. Medicine either works or it doesn't. And Tai Chi happens to be excellent as a way of preventing falls. Its utilization for other things is much more speculative, but teaching Tai Chi to people in senior citizen centers will help prevent potentially life-altering or life-ending falls. So we know that there is evidence for that. I also do it because I think it's fun. That's why I do it. But when you're thinking in terms of medicine, the standard is it helping or is it not helping? Is it meeting our needs here? Or is it just something that supposedly supports the immune system, but there's no measurable benefit? If you can't measure the benefit, there's no benefit. So where do you go to get good information? Glad you asked. Drug company ads? No. I'll explain why. Dr. Google? Yeah. Internet, more details. Books. I have some books listed, and I always give the citation from one of my professors in the first year of medical school. Books are the elephant graveyards where knowledge goes when it's getting ready to die. It's getting old and ready to die. It's not necessarily where you get the most up-to-date knowledge. I went to medical school a long time ago. Books keep up to date much more quickly. But here's some other people. Pharmacists have a lot of information they can share with you. The beginning of their training is very similar to medical school. When you sign that little slip of paper, you're giving away your permission to talk to a pharmacist, or your right to talk, rather. Second opinion, another doctor. If things are scary and flipping out, poison control, I used to call them from the emergency room when I was a doc working in the emergency room all the time. Librarians can help you do real research rather than the internet stuff. And support groups. National Alliance for Mental Illness is overall. CHAD, a great group for ADHD, the Depressive and Bipolar Support Alliance for mood disorders, and for rare genetic conditions. These are two wonderful websites that I've given you there. Drug companies, very quickly. Only two countries in the what we call the advanced or first world tolerate direct-to-consumer marketing. The United States is one of them, and the other is New Zealand, which has less people than Manhattan. And a lot of money is spent on advertising drugs, and we consume a lot of drugs in this country. So should you ask Dr. Google? Professor Neil deGrasse Tyson says it's a epitome of confirmation bias. Oh my God, a pop quiz on bias. Thank you, Professor deGrasse Tyson. So yes, this is how biases get reinforced through the popularity algorithms of the internet. The internet sends you information it thinks you want. That is confirmation bias defined. And that is why we're talking about some abstract philosophical concept at the same time we're talking about pills you might put into your child's body. So if you cleverly Google up Dr. Google on Google, like I did, I Googled the phrase, is it safe to ask Dr. Google? And even Google will tell you, don't ask Dr. Google. So if you ask the right question of Google, sometimes you will get the right answer. So where do we go looking for online data? 90% of all patients go online. Most patients use two excellent ones, Mayo Clinic and WebMD, which I have the links later, but they are not enough to allow patients to make informed decisions. They certainly can get you started. Discussions with doctors are needed, and there are reliable resources out there. Library, this is the New York Public Library, the main reading room, and over here, not everything on the internet is true. I love that. Here are two wonderful books. One is a basic intro. Again, it will raise your knowledge a bit. It's copy costs about $18. It's good, and you can see it's the fourth edition. Tim Willenz who is a local wonderful child psychiatrist, has updated it regularly. And down below is the best book I've ever seen on ADHD. Russ Barkley has also updated that. Here are two books. This is a deeper dive. These are books for professionals. Some parents get frustrated with not knowing that much, and they want to know what the doctor knows. Back in the day, way back in the day, you had to have a letter from medical school to get a medical textbook. We're talking like 50 years ago. These are wonderful books. The Carlat book is a paperback. Each drug has a single page. It's really nuts and bolts, really, really, really simple, really direct. The Maudsley is a very dense book. It gets updated like every 18 months. Again, it comes out of the United Kingdom. It is virtually free of bias, and it is very thoughtful. Websites, WebMD, Mayo Clinic, NAMI I mentioned before. Be skeptical of people who have things that look pseudoscientific. These two, I used to have a million. I used to have like 4 slides with all these different links. These are my 2 professional organizations. They have within them carefully vetted links to other organizations that they're scrupulously followed that provide good information. So General Psychiatry Association, and then the Academy of Child and Adolescent Psychiatry with these links here, which will get you in to the sites for families within them. Highly recommended. So at this point, we're ready for a couple of questions. If you got any questions, I'm going to stop my share, get back out, take a look at everybody, and maybe we'll take some questions.
Yeah, before we do so, I just wanted to say thank you. That was a very, very well thought out presentation, and I really appreciate it. And what I'm going to do now is I'm going to stop the recording. So if anyone has a question, wants to come off mute, ask a question directly, feel free to do so. You can also put it in the chat and I can read it. So I'll open it up.